So hello everybody, I'm Olli Halminen, senior researcher from the University of Eastern Finland. I have a title of docent in health economics, especially register-based effectiveness research, and today I will be talking about economics of aging and dementia. Last week I was asked to first explain what is health economics, so I will do that. After this I will explain my methodology or register-based effectiveness research. And then I will move on to tell how to manage the care system for older people and raise up some key open research problems related to dementia care system. Just as you know, I will be talking, when I'm talking about health systems, I'm talking from Finnish perspective. Finnish health system is Nordic universal tax-based health system, so it might not be generalizable to all other countries. Why and what is health economics? Imagine buying a kitchen table. A kitchen table is quite a, normal market product. If you go to a store, all the prices of the tables are visible. You can probably choose which store you go to when you purchase a table. You likely have clear preferences on what kind of table you are looking for, and your decision on which kitchen table you buy will likely not affect the health of your spouse or family members or neighbors, unless, of course, it's an extraordinarily bad table. However, already in 1960s, it was understood that medical service market differs to such a large extent from what we understand as a normal market condition that it should be studied separately. First and foremost, demand for healthcare, it can be unexpected and it can be really severe. Any one of us might wake up in the morning feeling perfectly healthy and end up by the evening in a hospital receiving an emergency surgical operation. Also, if you get an emergency surgical operation, it might have risks. Even a routine operation might also cause several health deterioration. So it's kind of tricky to give a price for a service that has such large risks. Also, there is this thing economists call externalities, that health of your child, for example, might affect your own health, resources, and financial situation. Similarly, taking a vaccine has effect on people around you. Because of these, national care systems typically bear much of the financial risks involved with health, leading to a situation that patient prices are also much lower than the actual cost of the service. On supply side, professionals in healthcare system, they have much more information than patients. If they recommend that you get a laparoscopy or appendectomy, you might not have much to say about that. And because of this, there is much regulation in this industry also. Professionals require training, and there's also these ethical considerations constantly present. If you're in private hospital and you get paid for each service, there is always a risk of overtreatment. And in a setting that there are too little care resources, you might have to prioritize other patients and not give care to others. So there are these ethical considerations that also muddle up the system and doesn't work like a normal market. So what do we study in health economics? All kinds of situations where you can either apply economical methods or study phenomena that are economic. In individual level, we might study that what affects health and care costs. Does your income level affect your care costs? Does nutrition you are getting affect your healthcare costs? Also, is treatment cost effective? Most of you might think, when you think of health economics, you might think of studies where new pharmaceutical products are compared to old ones and see if they are cost effective. Also, we have regional research For example, we might compare hospitals to each other. Are they effectively functioning or productive? Or does some region have more hospital use than the other? And on system level, we might study what is the current health status of our citizens, how much are we spending on care, is the care we are given distributed equally to all the citizens, are pharmaceutical products used properly. Of course, we might also try to predict the future and see what will be, for example, the workforce requirements in the future. Registry-based research. Finland has, when compared to other nations, at least in Europe, really high quality registry data. We have data on basically all publicly offered healthcare services and social care services and primary care services. And researchers can have access to this registry data maybe a couple of years later than the care has been given, but the data is accessible. This can be also combined with information on private care that has been reimbursed from public money, reimbursed prescription drugs, laboratory measures taken or vaccinations, for example, causes of death, also background informations. For example, we might have marital status, education, and even income information can be combined with the data to form different kinds of analyses. One example of these registry studies is this Finnish anticoagulation in atrial fibrillation project, or FINACAF, in which I have been working as a chief statistician for a couple of years now. In this study, we identified all atrial fibrillation patients in Finland during 15 years. There were 400,000 of these, and the data has been studied by over 40 researchers in many sub-projects. There are 17 ongoing doctoral theses. Most of them are medical ones, but this one is by an article by my PhD supervisee Ossi Lehtonen, his first article in thesis, in which he studied the cost of care for atrial fibrillation patients 12 months before and 12 months after the diagnosis of atrial fibrillation. The pharmaceutical groups here are people who receive no oral anticoagulation. Atrial fibrillation means that your heart is not pumping properly, and it increases majorly a risk for stroke. Usually you need anticoagulation to prevent strokes. People who receive no anticoagulation are likely too sick to receive the medication. Then there's warfarin, which was the older drug used for treatment. It was a bit unstable. And then there's direct oral anticoagulants in blue, which is the novel, more expensive medication. But we could show that still when taking into account the cost, direct oral anticoagulants were still much more cheaper for the public than warfarin. This is not trivial. I think direct oral anticoagulants, their public reimbursement now is something over 100 million euros per year. So it's one of the biggest pharmaceutical groups that are reimbursed. So it should be cost effective. I'm now starting a new oncoming dementia project in which, quite similar to FINACAF, I'm identifying all Finnish dementia patients from the past 20 years. They are mostly aged 70 to 90 years old, and some of key research problems I'm presenting soon, I'm going to study with this dataset. There is also this survey of health and aging and retirement, which is also quite applicable for dementia studying throughout Europe. It's different kind of dataset. It's survey all 160,000 participants have been interviewed for 1 hour or so, so that we kind of well know their current resource use and everything. But there are different kinds of datasets related to dementia which may be used. Now let's move on to today's topic, which is economics of aging and dementia and how to manage these both. Usually when people talk about aging, they mention the old age dependency ratio, or what is our ratio of working people and pensioners. And this is a really relevant question also of cross-generational justice, for example. But from health economics perspective, the interesting population groups are a couple of the oldest ones. In this graph, the teeny tiny one, they're over 95 years olds, is expected to triple in the next 20 years. And also the age group 85 to 94 years is expected to double in the oncoming 20 years. These two groups are also ones with most of the service use, and there are lots of comorbidities also that rise by age. In the picture you can see incidence of atrial fibrillation that grows the older you are getting. Here in the middle, this is one of my favorite graphs. Is aging related to costs? But here, a study from Norway plotted nicely what is the average healthcare cost by age. And here we can see that when you are a baby, your organs are still forming. Some babies require quite much healthcare. Then it dampens down before it grows. For working age population, typically women are using a little bit more healthcare services than men, possibly due birth giving. It's also a multifactorial phenomenon. And then the costs start to rise. We start getting breast cancer, prostate cancer, other types of cancer, then heart attacks, different kinds of cardiovascular diseases. And in the end, there is the dementia that is getting more and more prevalent, which can also be seen in long-term costs. Many of the studies previously did not include long-term care costs in the data possibly because the data was not available. But now we can understand that long-term costs are a key driver of costs when it comes to people over 80 years old. How to prevent these costs? In an ideal situation, such as in atrial fibrillation, we could have this nice little medication that could prevent your moving from home to a 24 care setting outside of your home. This would be nice, but it's quite more complicated. Instead of one medication, we don't have such effective medications that could prevent the 24-hour care transition, but different factors are related. Are you having some informal caregiver, home care, meal services, cleaning services, but also potential means to prevent are physical activity, nutrition, lifestyle, smoking, and sleep. How is smoking, for example, related to prevention of dementia? My personal hypothesis is that your biological age is just younger than your peers if you have not been smoking for 50 years. So this is why it seems that not smoking prevents dementia. This graph is not astrology. It's from my doctoral thesis. It was in the field of industrial management, and I wanted to create a managerial framework for measuring the effectiveness of care system where there's long-term states where people can be short-term service use, and then some input condition and unwanted and preferred output conditions. From this, I adapted for dementia setting before this presentation these 6 goals that potentially can be given for a system that wants to increase the cost effectiveness in care of dementia. These goals would be preventing dementia whatsoever by increasing population health, reducing transitions to 24-hour care setting, coordinating home care so well that people would prevent unnecessary hospital visits, curing dementia maybe with some medication, reducing mortality, and increasing cost effectiveness of each care service provider. For example, digitalizing services that are now not efficiently organized. Easier said than done. It's easy to list those here, but managerial frameworks usually are good at goal setting, not telling how to actually manage these goals. From economics perspective, lastly, there are 5 key open problems, I think, that we are researching currently. Firstly, this a little bit funny question. Does aging actually cause cost rise? So is this non-issue actually? The debate has been going on for 20 years now that is actually living longer increasing our costs of care, or is it just postponing them until we die? So is our biological age for 80-year-olds younger in the future than now? This is also called as the red herring hypothesis, that costs will not rise by aging, but they are compressed near death. And there's been a lot of articles about this topic. And I think after 20 years of studying, research is still ongoing. And I'm starting one master's thesis project on this, for example. And I think both increase of costs is visible and postponement of costs. Another good question, will novel Alzheimer's medication fix everything? Will this become a non-issue? Promising new Alzheimer's medications have been presented to the market. They have been marketed as first drugs to measurably remove amyloid proteins. So there's a biomarker that you can actually measure that, yes, the brain should be healthier with less amyloid proteins. However, a recent Cochrane review stated that although, yes, the biomarkers are looking better, clinical effects are still trivial or absent as of current. And cost of the medication is high, and it's only safe for specific gene groups, so it's not even applicable for all the patients. But who knows? Developments remain to be seen. There might be technological advancements. We might get more effective drugs, or, for example, patents affect prices. So even though the medication is now too expensive, the costs might come down in some point. Another good question, there's a lot of research on how much services are we actually using. So when I talk of moving to 24-hour care, it's a good question. Is it actually cost effective to keep person at their home if they are, for example, getting more than 1,000 yearly visits to their home by home care professionals? And getting a good comparison groups for this is really difficult because in one municipality, you likely if you're not getting 24-hour care, you're more healthy than the persons that are getting those. So similar to home care versus not receiving any home care, there also showing the causality is really difficult. Usually people that get home care are more sick than those who are not getting. Other questions, will we run out of care personnel in the future? 15 to 20% of people aged over 85 are requiring 24-hour care currently in Finland. So it's a good question for all the regions. Will we have enough care personnel in Finland if there's also the similar aging happening throughout Europe, for example? Do we need some less educated professionals? Can I don't know, 1 year of training be enough for giving some kind of care services? Do we need different kinds of facilities or integrated care centers? It's a good question. And finally, if I'm talking about public and private services, I'm not talking about informal caregivers, which actually form a huge proportion of our care system. So informal caregiving, in some cases, it's a major burden to family members, health burden, and also might be a cost burden, but not always. And there are lots of moral and ethical issues related to this. But it's also a really big question. Some studies have approximated that 60% of care we are giving for older people is given informally by family members. And in Swedish study, informal caregiving costs were estimated to account to 3% of gross domestic product, and 55% of the costs were people getting out of their jobs in order to be able to give care to their family members. All in all, aging and dementia are something that are situated within our economic system. They are not outside of it in any way. And there are thus many questions, open questions to study with economic methods and approaches. Thank you.